pleasure to be here. So this is a conference about data and policy, and my area of focus is poverty. So I thought I'd start with a few sobering statistics about world poverty. So a little bit less than 1 billion people live in extreme poverty, which the World Bank defines as less than $1.90 a day. And somewhere in the order of 9 million children a year die under the age of 5, mostly from avoidable causes. So in the time that we've been together, about 50,000 kids have died for avoidable causes. And a little more than 30 million children are unimmunized. So given those sobering statistics, I'm going to start with a somewhat humble or modest goal to convince you in the next 15 or so minutes that we should be at least a little bit more rigorous in the way that we address the most pressing social problems of our time than medieval doctors were in treating diseases. So you're all familiar with leeches. The problem with leeches was that when doctors would apply leeches to the patient, they'd say the patient gets better. They'd say, look, the leeches worked. Patient got worse. They'd say, oh, it's too bad that the leech didn't manage to save this patient. They were too far gone. And the problem is that there's no counterfactual. It's very hard to know what would have happened if you didn't give the leeches. So thankfully, modern medicine has a better approach. We use randomized controlled trials. We can get good data about what works and why. And rarely do we get silver bullets. Rarely do we eradicate a whole disease category all in one blow, but progress is made over time by solving particular problems, and cumulatively, we are much better off as a result of the scientific rigor that we have in the medical world. So how does this work? Well, the problem is correlation and causation. How do you know that the thing you're doing is the cause of the effect that you see? And there are tools within science that allow us to be pretty sure that we can disentangle this. If we flip a coin, put one group into a control group, one group into a treatment group, if we run this rigorously enough, we can be pretty confident that it's not differences in the population that are causing the change, but rather that the change can be attributable with a margin for error to the problem or to the intervention. So go back to the premise I started with. So you've got about 1 billion people in the world living in extreme poverty. What do you do about that? Let's imagine that you're a government official at a large development agency, or maybe you're working in a philanthropic entity, and you're trying to figure out how do we actionably deal with global poverty on that scale. So there's a raging academic debate. Maybe aid is the answer, or maybe aid isn't the answer. Maybe aid is a problem, and maybe the free market's an answer. And the problem is we don't know. And even worse, we'll never know. And part of the problem is that we can look back over time at what happened to a continent or a country, and we can say, well, there was a certain amount of aid or there were a certain number of interventions, but there's no counterfactuals. We're left there with the leeches and the doctors trying to figure out whether the patient got better or didn't get better because of the leeches. So that's kind of a discouraging thought, but maybe I can take a slightly more optimistic view on the second statistic. So let's say you work for a government or a large philanthropy. You're at the Gates Foundation or at the Gavi organization, and you have a few $1 million, or maybe a little bit more than that, and you want to take a chunk out of this statistic that I just cited, about 9 million kids a year dying from avoidable causes under the age of 5. That seems like a worthy policy goal, right? But this is a hard question, right? Because if you're right, that's great. If you're wrong, people die. You know, this is a life and death decision, so you better be right. But how do you know what works? So it turns out that we can run the same kinds of experiments that you run in the medical context to try and figure out the answer to this question. So let's say your hypothesis is that vaccination is really going to be one of the main tools that you're going to use to prevent these avoidable deaths. And this is sort of a last mile problem, right? We've got the technology, we've got the infrastructure, and yet we have trouble delivering the vaccines to the kids who need it. And this isn't a lack of motivation or love for the kids. You see these very crowded hospitals. If these kids actually get sick, their parents are going to spend all their money, all their time to try and make them better, but you have these empty vaccination centers. So let's run an experiment. So what we're going to do is we're going to create 3 groups. With the first group, we're going to do what we're doing all along, right? We're going to use the public health infrastructure that we usually use. With the second group, we're going to create a vaccination center, and we're going to make it really, really, really easy for these moms to get the kids vaccinated. And then we're going to take a third group, and not only are we going to make it really, really, really easy, we're also going to give them a little incentive. We're going to give them a little incentive. We're just going to give them a kilo of lentils, okay? And this is an answerable question. So it turns out as to this question, the answer is not only is it more effective, but it's more cost effective to not only make it easy, but also to give a little incentive. So this is an actionable policy answer, okay? And so to give you a point of reference, when there was the Haiti earthquake, the world responded. It was an emotional moment. We spent about $10,000 per life lost in Haiti. This intervention, $300 will save you a life. So we do this with all series of social policy problems all around the world. Turns out that if you want to fight malaria, it's pretty cheap and pretty effective to give to give bed nets. Okay? So all across the world, we're running 770 ongoing and completed evaluations in 68 countries, and this is actionable research, right? We're actually making a dent. So by our estimates, about 200 million lives have been touched. Right? So these insights can be taken in other contexts, not just the medical context. So let's say you're worried about schooling. Okay, so there's about 72 million primary school-aged kids who aren't going to school right now. A lot of them are girls. Okay, so let's test a bunch of things. Maybe we should invest more in teachers. That seems like a good idea. Maybe we should invest more in school nutrition, or maybe it's school uniforms. So we can't do all of these things, so we have to choose. So let's run a bunch of experiments. So it turns out that sometimes you get surprising results. I started with leeches. I'm going to talk about intestinal worms. So it turns out that if you've got intestinal worms in your population, a really cheap way of investing in education is to give pills at schools to relieve those worms. For $3 of an investment, you can get a marginal school year in an impoverished country. So these are actionable results. So the whole evidence-informed movement in global philanthropy has come out of this research finding called Deworm the World. So as was mentioned, my background, I'm a lawyer. I'm actually not an economist. My background's mostly been in government. And about a year ago, I was asked to go and be the first executive director of JPAL North America to bring this approach to fighting poverty in an affluent country context. And this comes at a time of growing emphasis on evidence-based policy making across Europe and the United States. As was mentioned, I came out of the White House. We recently launched a social and behavioral sciences team to run some of these evaluations in the government. There's been an evidence-based policy commission. Pay for Success is a growing movement. And so what we're working to do is figure out how to bring this approach in an actionable way in the developed world. So let me take an example. We have, as you know, had a major policy conversation in the United States over the last 3 years over expanding health insurance. So this culminated in Obamacare. Well, in the run-up to that, there were a lot of talking points on both sides about what would happen if you expanded health insurance to the poor. Now, some of these were ideological, and some of them were not fact-based, so there were arguments about the role of government and about taxes, but there were also real economic arguments about what would happen to a population if you increased access to health insurance. And it turns out that we can actually study these things. So the state of Oregon had a little bit of money, but not enough money to cover the entire population. And they did what governments sometimes but rarely do. Instead of doing it first come, first served, they ran a lottery. Well, this created the kind of randomized control experiment conditions that you can run in science. And we were able, or scientists were able, to look at what happened to the group that newly got insurance and what happened to the population that was a perfect counterfactual, statistically identical. And this was able to cut through the rhetoric and the talking points and actually give us some good data on what happens. So it turns out that actually utilization of care increases a little bit when you take people off of insurance. You give people insurance, they go not only to their primary care docs, as was hoped, but they go to emergency rooms. But there are also really significant consequences in terms of insuring them against risk. So the catastrophic out-of-pocket costs that people experienced went away. Actually, mental health was significantly improved, but there weren't short-term effects on physical health. The point, though, is that we then had facts, and we could use those facts to inform a policy discussion. So does this work in other contexts? So in the United States, we have a problem with crime, and this problem with crime is deeply embedded in our problem with poverty and our problems with race. So, around the world, about 500,000 people are murdered every year. This is a problem that disproportionately occurs in poor communities. And I want to tell you about an anecdote. So in June 2nd, 2012, a boy named Calvin Carter, age 17, shot a boy named Jamal Lockett, age 16. They had a fight over a bike. This wasn't something they planned to do when they woke up in the morning. These weren't this wasn't necessarily an irredeemably horrible person. A fight escalated, got out of control. Boy shot another boy. The boy dies. The other boy is in jail for life. So there's a question. Is there anything we, policymakers, scholars, is there anything that we can do that would have averted a tragedy like this? Well, it turns out there's actually some evidence, and some evidence from the developing world, some evidence from the United States that helps us to make some decisions. So in Liberia, a war-ravaged country, J. Powell affiliates ran some experiments on what could you do with cognitive behavioral therapy. So slow down your thinking, train people to stop, look, and listen. Figure out, are there psychological techniques that can allow people to de-escalate in situations like the fight over the bicycle. And it turns out that when you do this with not a lot of expense, you can actually decrease propensity for violence pretty dramatically. And so we ran this experiment again, or an affiliated professor ran this experiment again in Chicago, and found that if you take at-risk kids, randomly assign some to the control group, some to the treatment group, and give them this kind of an experiment with cognitive behavioral therapy, looks like it turns out that you can get real demonstrable results, and that is turned into a program called the Becoming a Man program in Chicago, which has a real possibility of making a dent in our violence problem. So this all sounds great, right? And the wrap on this is that it takes a lot of time, and it's pretty expensive and difficult. And we're the first to admit that these are not necessarily things that fit every circumstance. But sometimes getting real facts and real evidence in an actionable way is hard but important. And sometimes we can do some things to make it a little easier. So let's talk about a few things we can do to make it easier. If you can get access to administrative data sets that are way richer than anything you could hope to get with survey data, you can make it cheaper and you can make it more effective. So one of the things that we are focused on is trying to figure out ways of increasing linkages of data sets, giving scholars access to important records about labor outcomes, about education outcomes, about health outcomes, in a way that protects privacy and security, but allows us to answer these important policy questions. The other thing that we need to do is we need to teach governments. So I come out of government, and on my best days, when I was trying to answer an important policy question, I'd bring in the lobbyist from one side, I'd bring in the advocate. Maybe I was smart enough to know that the answer wasn't necessarily right in between. I'd call up a scholar who might know something about it. I'd Google it and learn a little bit about it. So training government in how to be good consumers and producers of evidence is a really important strategy for building a movement for evidence-based policymaking. So what we're doing is we've developed a state and local government initiative, as well as a healthcare initiative, where we take some of the most innovative governments answering questions on education, on health, on labor, on crime, and we work with them. We work with them on a specific policy problem. So maybe they think that summer jobs programs are going to have a measurable effect on decreasing interactions with the criminal justice system, or maybe they're coming up with a new way of delivering services to people who are fighting with opioid abuse disorder. So we work with them on a specific question, but the other goal is to train them, to create a culture within their policymaking environments to be better producers and consumers of evidence, to do smarter piloting. And I want to return to where I started, which is the medical example. So the temptation in the aid context is the silver bullet, right? Is the cure for cancer, right? But actually, that's not really how it works, right? So the vision for the future is actually not one easy solution to poverty. The solution is a generation or a century of an approach to solving problems that takes rigorous science, answers hypotheses, and builds over time towards what works so that we can invest in things that actually change people's lives.